Okay, spinal disorders. We're talking about spinal injury, specifically spinal injury. I love these pictures. Spinal cord injury. These are the most common causes of spinal cord injury. Number one, motor vehicle accidents. Again, not testable, but what I am going to point out is that we have an acute phase, and then we have the recovery, rehabilitation, rest of your life phase. So I'm setting the interventions apart into the acute phase and the recovery, rehabilitation phase. The acute phase, we're talking about the first 2 to 3 months after spinal injury. That is when we have a lot of cord swelling. They're different interventions than in the recovery, rehabilitation phase. So the first part of this lecture that we're going to go through is what we're doing in the first phase of injury, and then we're going to be talking about some common rehabilitation complications. So let's talk about the acute phase, spinal cord injury to the first few weeks after spinal cord injury. The cues are pretty obvious. It's spinal cord injury. This is where we have compression or fracture of one of the bony elements, either a vertebrae, the actual cord itself, the ligaments. And the problem is once you damage one of the supporting vertebrae or ligaments, you have a risk of increased damage to the actual cord itself, carrying the signals. So what we're going to be looking at is there's two kinds of things to help us figure out. Again, the only way to diagnose the actual injury itself is via MRI or CT scanner, but our assessment is going to be key in determining the location based on their motor and sensory abilities. So the spinal motor exam and the spinal dermatome exam are going to be just as important as if you have a patient with a head injury or a brain injury, that we're going to be looking at those motor and dermatomes to pinpoint our injury area or our areas of swelling. So let's look at the different kinds of injuries. Again, you're not going to be assessing what kinds of injuries there are, but there are multiple different kinds of things that can damage the spinal cord or even rupture or break the spinal cord. These are just when you say they have a flexion or a hyperextension injury, that is where the neck is either pushed forward really hard with a lot of force, and the posterior ligaments are ruptured, leaving the spinal cord to kind of cave forward. A hyperextension injury, the head is pushed back with damage. Compression fractures, the actual vertebrae shatter, and bony fragments can get into the spinal column. And flexion rotation injuries actually twist or rotate the ligaments on both sides. So the specific cues, though, that you are going to see are going to be related to the level and degree of injury. So I wanted to point out your little map over there on the side. You'll see from this map that they have color-coded your cervical nerves, your thoracic nerves, your lumbar nerves, and your sacral nerves. Luckily, somebody labeled them very well, and there are C's for cervical, T's for thoracic, L's for lumbars, and S's for sacrals. Thoracic nerves are specific to chest and abdomen, to your core muscles. The cranial nerves are where your vital functions are. The cervical levels. The diaphragm is controlled at level C3. So any injury above to C3 or above damages your diaphragm. So the diaphragm being at C3 is pretty important. Your upper extremities and upper arms are in the cervical and in the thoracic area. So what we're looking at is we kind of have some set levels that we like people to know. And I do believe we have them here as well. C4, C6, T6, and then kind of the lumbar areas. But C4, C6, those things are nice. Those are good to know because those are going to be where we have our diaphragm, chest involvement, and T6 is really, I think in the neuro assessment video, we pointed out that anything above T6 is going to have some kind of respiratory compromise, just the degree, and things below T6 are not going to have respiratory compromise. So when we're looking at the cervical vertebrae, C4 or higher is going to be complete loss of respiratory muscle function because we're damaging the area that innervates the diaphragm. You're also losing all of your upper and lower body function. So C4 and higher, a C1, C2, C3, C4 could be pretty debilitating if it is completely severed. We're going to show, too, that there's complete versus incomplete. You think everything would be easy. It is not. Most of the time, the spinal cord is not completely severed through, and you end up with an incomplete injury. But the nerves that come out from those cervical areas, C4 and above, are your your diaphragm. So diaphragm, head, neck muscles are C4 and above. So if you are damaged C4 and above, you usually lose your respiratory muscle function, and you are quadriplegic. C5, C6, you may not require mechanical ventilation. You still have your diaphragm intact, but you have weak thoracic muscles because you lose everything below C5, C6. If it's complete, you have partial loss below if it's not complete. But a complete means the spinal cord is severed there and no more nerve transmission will go below that level of injury. So when we have an injury to the spinal cord, so let's see this guy over here. If this is C1, C2, C3, and C4 here, then if this area right here, if it is not completely severed, you may regain function below there. What happens when this spinal cord is compressed like this is it swells. And so while it is swollen, there is nothing going past it. All the nerve signals down there get blocked. There is no function below the level of injury while that cord is swollen. Once things start to, the swelling, if it did not get completely severed, and now the swelling goes down, then there might be some signals that get through. Not fully, depends on the permanent damage to that area of cord. So that's complete versus incomplete. Complete would be either we completely sever the cord. So if this bone goes through and completely severs the cord and it is broken, then nothing will ever get past that. If it does not completely sever it, but it just swells, then some recovery might be possible. So what looks like a complete injury, after the period of swelling goes down, you may see some function return. And the only way to tell complete versus incomplete injury is via an MRI, a detailed view of the soft tissues and areas on the spine. So complete versus incomplete. Again, complete means the area is either so swollen that nerves can't conduct through it, or it is so severed that nerves cannot conduct through it. An incomplete injury is where some of the cord is damaged, but other parts of the cord are intact and some transmission gets through. That's an incomplete injury. But in general, C4 and higher, we're talking about complete now. So when we are looking at this, we are talking about complete. That if you have a complete injury, C4 or higher, you've lost your respiratory muscle function, you'll probably require mechanical ventilation, and you are quadriplegic. C5, C6, you will be quadriplegic, but you may not need mechanical ventilation. but you will need a lot of support, and you'll have some shoulder bicep ability, but not hands, not arms, not full abilities. And then T1, T6, you're now paraplegic. All your arms and your hand ability is in your thoracic area. So if you've severed or damaged below the thoracic area, then you are going to be paraplegic. So this is where paraplegia starts. So anything cervical, you're going to be quadriplegic. But C5, C6, the degree could vary. There could be some shoulder and bicep ability, but you will not have full range of motion of your upper arms. So C is quadriplegia, thoracic and lumbar are paraplegia. Okay. Just very, very basic. There's so many extenuating circumstances that I'm just giving you basic information. Cervical, again, quadriplegia. Thoracic and lumbar, paraplegia. And then the level of thoracic involvement is going to depend on whether you have working strong chest muscles or not, or strong core. But you have varying abilities all the way through the thoracics to the lumbars. You will be paraplegic if you have broken anywhere in the thoracic lumbar area, but the degree to which you have strength for coughing and stuff depends on how much your chest muscles or your abdominal muscles are involved. So complete cord injury, again, is total loss of sensory motor function below the level of injury. An incomplete cord injury is, again, where part of the cord is damaged and another part is intact. So some nerves travel through and some do not. The incomplete spinal cord injuries are so complex that I kind of summarize them to the best of my ability here so that it's easy to understand. Recognize the names of the spinal cord injuries that are incomplete spinal cord. It's anterior, central, and posterior, okay? And then you have Brown-Séquard and Cauda-Equina. Those 5 are incomplete spinal cord injuries, and it means that some of them have motor deficits and sensation intact. Some of them have sensation intact and motor deficits. There are such a variety that if you just can remember the names of the spinal cord injuries that are incomplete and be able to recognize them as incomplete injuries and know that they have some difference. I tried to summarize them in a list less than 2. That anterior cord will have paralysis, but they can still sense touch, vibration, motion. They lose muscle function and pain and temperature regulation. Central cord, usually motor and sensory loss, but sometimes something can get through down to the legs. Posterior cord, again, poor coordination, impaired touch, proprioception, vibration, but pain and temperature intact. So anterior and posterior are opposite of each other. Brown-Séquard is where they are intact on one side but not the other. And Cauda-Equina is disrupted motor function to the lower extremity. So not necessarily full paraplegia, but bowel and bladder issues. So again, I don't want you to spend a lot of time on incomplete. I would like you to recognize the names of them and know that they are not complete paralysis. It depends on the amount of damage to the actual cord. So let's look at what we're looking for. So the cues are the exam, and I don't think I had a picture of your dermatome exam here and your spinal cord exam that was in the neuro assessment. I should have put the slides over here too. But for your primary injury, sorry, I went into complete and incomplete. For your primary injury, we are going to look at all motor movement and find out, do you have areas that are intact or not intact? And then you'll correlate them to the level on the spine. So you can move your hands and you can move your hands, you can move your shoulders, but you have weak respiratory function. You're somewhere in the upper thoracic level. You can move your hands, you can move your shoulders, but you have a strong cough, good incentive spirometer, but you have, weak core. It's hard for you to sit upright. You have injuries in the lower thoracic area. You have lost feeling in the legs, you've lost feeling in the arms, and you are not breathing effectively spontaneously. They'll say you have a higher cervical cord injury. So we're going to be looking at all of the nerve sensation. We're going to look at all the motor ability, and then we're also going to look at the dermatomes. Where do you feel it? And you check dermatomes for your patient. You can use alcohol wipes. You can use little syringe needles, little low gauge syringe needles to do pokes. But we are looking for levels that the sensation comes back. So you'll take your dermatome chart and figure out where there's no sensation, where there is sensation, and map it on the chart. But really, the true diagnostic way to figure out where the spinal cord injury is to go to the MRI and look for a spinal cord injury. So dermatome and spinal cord assessment, and I do believe I have this in a couple later slides. But so the primary injury, it exists. There is some swelling going on. We have some injury to the cord. There's decreased motor. There's decreased sensation. What we're looking for is we can't fix the primary. We can't fix the injury, but we can watch for secondary injury. Secondary injury involves the swelling of the spinal cord. And we have two different kinds of swelling of the spinal cord. Secondary injuries begin several hours after the injury and begin to recede after a couple of weeks. It may take a month or two for swelling to fully recede in the spinal cord. But while we have swelling, just like with a brain injury, and we have swelling, we're going to have neuro deficits. While we have swelling, we're going to have motor and sensory deficits. This is also called the shock phase, although spinal shock has nothing to do with your blood pressure. I don't know exactly where the confusion is, and there's a great deal of confusion. Some people call neurogenic shock spinal shock. Spinal shock itself is swelling of the spinal cord. Spinal shock itself is just like when we were talking about the guy with the neck. Maybe his cord is not completely severed, but it's so swollen that nerves cannot transmit past that swelling. That is considered spinal shock, is when you have so much swelling and inflammatory response that the nerves cannot get messages through. And unfortunately, some of this swelling extends the injury. So we're going to draw a very well-drawn man here, again, with my well-drawn men. So we have our little man here, and he's not thrilled. He's not having a great time and he doesn't have a very good neck, and he's actually kind of ugly. I'm sorry, little man. I didn't mean to make you ugly. Let's say he's got an injury here, and he's got C1, C2, C3. Let's give him a C4 injury. So he's injured here. He's got a posterior injury. And let's see, C1, C2, C3, that's C4, C5, C6. Okay, it's not a very good drawing. It's too squished now. I didn't give myself space. All right, so he's damaged C4. At this point, he has a lot of swelling going on here where he has his damage. Unfortunately, this swelling can expand up. He's got an injury at C4, but look at this swelling. The swelling has actually caused the injury to rise up to C2 because of this swelling, nerve transmission isn't getting past C2 because of this swelling area. So what I want you to remember about spinal shock is that it is swelling, and swelling can affect up to 3 to 5 levels above the injury, which means that you can have motor and sensory problems above your injury level. So this patient broke at C4. He should have an intact diaphragm. Why now can our sweet little man here not breathe well? Because the swelling has now affected to up to C2, and now the innervation to his diaphragm is not happening. So spinal shock is swelling, and that can actually cause a temporary increase in your injury level. He doesn't have a C2 injury, but right now he is so swollen that he is appearing as a C2 injury. Now, as he gets better and the swelling starts to recede, now we have return of function back to C4, and now his diaphragmability comes back. So during spinal shock, that is basically have lost your motor and sensory below the level of injury, but you can swell, and it's a temporary extension of your initial spinal injury. So if we have a patient that has a T4 injury, so let's look up at our map up here. Let's say that we have a T4 injury. So here's our injury right here at T4. With spinal shock, this injury may swell up even higher. So maybe they lose their hand functions. But then as spinal shock starts to recede, they get it back. So again, spinal shock, think of spinal shock as swelling. The spine is in shock, and it appears worse than it actually is. So we can't really prognosticate spinal cord injuries, because what's happening when this cord is swelling is that it's cutting off blood flow to itself. So this may become permanent damage. And that's why our interventions are involved in reducing secondary injury. Because if this swelling stays for a long time and cuts off blood flow to the cord, then now your injury has extended to T1, and you might have lost your hand function. Whereas your initial injury was to T4, the cord is broken at T4, but if you let secondary injury swell and continue and don't treat the secondary injury, that can lead to permanent hypoxia. Very similar to if you have an MI, you want to reperfuse it as quick as possible so that you don't have lasting damage. Again, in the spinal cord, during the spinal shock stage, we do want to make sure that we are perfusing and getting good blood flow to the spine so that it can heal and reduce the amount of swelling. So spinal shock is a temporary extension of your initial spinal injury, could affect up to 3 to 5 levels above the injury, and it would be a worsening of the motor ability. So you come in with, your paraplegia. So our little man here in the upper map, this is another little man here. I'm just not drawing him out. He has a T4 injury. So when he first came in, he could fully move his hands, his arms. He was just paraplegic, and he was having a little bit of shortness of breath because he was really having trouble getting those chest muscles moving. But then as he stays in the hospital, all of a sudden now he can't feel his hands. He's getting a little bit clumsy and discoordinated on his hands. His dermatomes are starting to rise there to cover the hands, and he's starting to lose sensation in those hands. This is spinal shock, and you can tell the patient that we are doing everything we can to reperfuse the spine. The swelling will go down, and hopefully you will regain your sensation in your hands. And then when you treat him and intervene and keep things stable and get the swelling back, hopefully we have not caused any damage to the spine, and the swelling recedes back to T4, and then hopefully there's some healing after that. So spinal shock, think to yourself, is swelling. Neurogenic shock itself is a problem T6 and above only. So this little man with a T4 injury would definitely be at risk for neurogenic shock. Not every patient. This guy was at the bottom here, he's C4 because we drew him so beautifully. He's a C4 injury. The guy at the top there, he's a T4 injury. Both of these patients are at risk for neurogenic shock, which is an actual change in your blood pressure. It is a distributive shock. It causes massive vasodilation and a decreased blood pressure because of vasodilation, and then a decreased respiratory and a decreased heart rate. And the reason this is because the sympathetic nervous system, so the parasympathetic nerve comes out of your brain and stimulates your heart and your bowels. These are bowels. Can't you tell? Those are great bowels. This is the parasympathetic nerve. So what does parasympathetic nerve do? It's your rest digest nerve. It comes out above the cervical injury. The parasympathetic nerve is free to go. It does not involve going down the spinal cord, whereas the sympathetic cord, the sympathetic nerves kind of come out and they innervate your diaphragm and they innervate your heart down here. This is the sympathetic system. So in this time of swelling, you can cut off some of your sympathetic stimulation. And the sympathetic stimulation gives you an increased heart rate. Let me not draw with yellow, sorry. Let's make it red because it makes things revved up. Rest, digest, slows things down. So the sympathetic kind of comes out here, it innervates your diaphragm, and it increases your heart rate. And it increases your blood pressure, increases your respiratory rate. But the problem is that now, because of swelling or damage, that is not working as well. So all that we have left is unimpeded parasympathetic stimulation. And so the parasympathetic rest digest is going to decrease your heart rate, decrease your blood pressure, because it's digesting stuff. Increase the heart rate, decrease your blood pressure, decrease your respiratory rate. It does all the opposites of flight, fight. And so that's what we're seeing is we're basically seeing complete parasympathetic response with no say-so from the sympathetic to be like, dude, you're going too low. So we're having a low heart rate, low blood pressure, low respiratory rate. Everything's just chilling out. And that low blood pressure is not good for our swelling process that's going on here. So this poor boy, he's swelling. That's what cut off the sympathetic stimulation in the first place, was all this swelling. And then you add more problems with decreased blood pressure. We're not getting good perfusion to there to help clean up that area. So that is neurogenic shock. Anything T6 and above, because the sympathetic nerves are coming out all the way down to T6. So sympathetic nerves are coming out in multiple locations. It's coming out at C3 here. It's coming out at C6 there. It's coming out at T1 and T2 because it's innervating the heart. The sympathetic nerves come out of the spinal cord at different levels, whereas the parasympathetic exits the brain and does not go down the spinal cord. So when you have a spinal cord injury, we run the risk of losing our sympathetic response, and unfortunately, that will cut off our ability to increase our respiratory rate, increase our heart rate, and decrease our blood pressure. So if your patient is going into neurogenic shock, it is in combination with spinal shock, because spinal shock is swelling, a patient in neurogenic shock will start to decrease their blood pressure, their respiratory rate, and their heart rate. And we need to do things to support those while they're in neurogenic shock. So we will talk about those when we do interventions. So hopefully everyone is clear on neurogenic shock, vital signs. And spinal shock is swelling. Okay, neurogenic shock decreases all your vital signs, blood pressure, respiratory rate, heart rate. Spinal shock is just swelling. Neurogenic shock only happens at T6 and above because that's where your sympathetic nerves are coming out. Okay, makes sense? We're moving on. Here's another summary slide about neurogenic shock. Again, spinal injury anywhere from C1 to T6 has a risk of it. Loss of sympathetic system, the parasympathetic nerve is going to town, hypotension, bradycardia, vasodilation, and also temperature dysregulation. And spinal shock, no effect on the vital signs, just swelling of the spinal cord. Oh, I didn't mean to draw that. That is just, hang on, let's move that down. I don't know why that's written all over your, scribbled all over. I have another picture of it on the next page. The spinal cord injury acute phase, the key assessments we're doing is the motor exam and the reflexes and the dermatome exam. Again, our exam is important to know whether spinal shock is happening, whether our injury is extending. You're in charge of keeping an eye on the level of injury. We're going to keep an eye on respiratory depth, strength, or oxygenation. If you have anything, I would do anything in the thoracic area or above, because let's go back to our map again. If you look at anything, I would even be any of the thoracics, because if you're at T12 and this swells up this way, you could get to the area where your chest muscles are, and those are helping you breathe. Your diaphragm will be intact, but I would want to keep an eye on those respirations for anybody with thoracic or cervical. We want to keep an eye on our respirations, and not just so much that they are breathing, but they are breathing adequately. Watch for labored breathing, weak, shallow respirations, an increased, a difficulty with shortness of breath, accessory muscle use. Again, those muscles are going to be weaker depending on the amount of innervation they have. Watch blood pressure, heart rate, respiratory rate for neurogenic shock. And we're going to keep an eye on our mean arterial pressure because we want to maintain perfusion. What do you think you want to keep your mean arterial pressure at? We don't have to worry about perfusing the brain, but we want to definitely perfuse the spine. So we're going to go with the same recommendations from that we had for neuro, is that we want our mean arterial pressure to be 70 to 100. We want blood flow to the spine. They will keep a little bit of a higher pressure to get MAP in there. We don't have to overcome intercerebral pressure, but we do have to overcome spinal pressure. And so a higher MAP will get blood flow to the spine to heal it. We're also going to watch bowel bladder function, because as you could see on your map back here, I should just have this map on every page. Let's go back. From your map here, you can see that bowel bladder function is down here. Those bowel bladder nerves are coming out down in your sacrum. The abdominal muscles, some of this innervates your bowel. Some of this area has bowel innervation here, but most bowel bladder is coming out down in the sacral. So almost every single spinal injury will have some kind of bowel bladder impairment going on. So we're going to definitely keep an eye on our bowel and bladder function as well. This is another look at the actual standardized tool for measuring spinal cord injury. I did have another tool that showed you a little bit more about all of the flexor exams, the wrist extensors, the elbow extensors, all the different exams you would do to check that. And you can see that they have the highlighted tests right there, the ones that they want you to do, and those are the ones that are in the assessment slide deck. I will maybe pull those out at some point and put them in this slide deck as well, just so we can refer to them. But you will be doing a motor exam of the major motor assessment pieces, which are going to be elbow, wrist, and fingers, because that will delineate levels and of the hips, knees, ankles, and toes. So you'll be constantly doing motor assessments. And then your dermatomes, this is where alcohol would be a light touch score, and pinprick would be a little bit more. You could use a pen tip or a pencil tip, or a pin, or like I said, a fine gauge needle to do tests, and you'll check the dermatomes all the way up, and where they lose sensation is going to be where you're going to mark it. So most places with spinal cord injury will have some kind of charting document like this, where you're going to be just saying where you have absent, impaired, or normal, so that you can kind of assess the level of injury there. So what are we going to do to treat these patients? We can't fix the injury. The injury has already happened. We are maintaining, we're trying to prevent secondary injury with our interventions here. Number one intervention is stability of the spine. Just like with a fractured arm, you're not going to go moving your arm all over the place. It's going to swell more. So again, we're going to do that with the spine. We are going to keep the spine rigid and stabilized in order to prevent swelling. It's the number one intervention to keep things from swelling. I mean, as soon as you break a toe, you put your weight off the toe and you don't move it. It hurts. It will also reduce swelling. The more you walk around on something that is broken or damaged, the more it's going to swell. So if you have a broken bone, it would be common sense to keep it stabilized, to keep the swelling down, and to maintain healing. So for the spinal cord. So we need to immobilize the spinal cord. We don't leave patients on backboards. We do take them off of backboards, but they can be maintained in cervical alignment with a C-collar, a halo brace, which is where they actually will put traction on the spine. You can have a brace, you can have tongs, we can put traction on it, we can keep that spine stabilized any number of ways. They can also use thoracic or lumbar braces depending on where the injury is. Cervical injuries will have a cervical collar, possibly brace or tongs. Thoracic and lumbar will wear braces. We do not want the patient bending, twisting, turning. They should be using immobilization devices at all times. We can, though, remove them so that we can keep the area clean. Just because they have a collar on does not mean we don't do hygiene around that collar. It just means that we have to support the head and spine. It's usually a 2 or 3 person job to do hygiene and care for patients because they need to stay stabilized while we have their brace off. Only a physician's order can discontinue a brace or a collar longer than it takes to do hygiene care. There is permanent cervical or spinal stabilization. They can do that internally with rods, bars, but they usually do it after spinal swelling recedes, so they're not going to go in there right away. I don't know if anyone's had a real bad broken leg, but they just put you in kind of an open cast, let the swelling go down, keep it immobilized, and then do repairs once the swelling has reduced. It's a lot easier. The tissue's not as friable, not as easily damaged. It's a much better situation to do a repair when spinal swelling recedes. Although if they're having worsening motor sensory exams and they're worried about losing spinal cord function due to spinal shock, they may go in and do some stabilization prior to. It's up to the physician. But immobilization, whether we're doing it externally with traction or with braces or with collars, or internally with surgical stabilization, immobilization is the key thing to keep swelling down. So we will maintain spinal stability at all costs. Here's all the different kinds of braces, collars that you can have. A high thoracic, low cervical injury would probably get something like this. This will hold C-spine and thoracic in there. This would be for just possibly thoracic or lumbar. And then, of course, you have your cervical collars as well. The other thing we're going to do is make sure, just like with the brain, we want to make sure that there is plenty of oxygen and perfusion to the cord to heal it. So maintain spinal oxygenation, keep your, I guess it doesn't really matter about neutral head position. We can get rid of that. I think I might have copied this off of the neurosite. Open airway, cough, deep breathe, and send a spirometer. Make sure that we're not getting any respiratory infections. Keep your perfusion. I said MAP of 80 to 100. We'll just keep 70 to 100 for both scenarios. 70 to 100. Keep MAP 70 to 100 to maintain spinal perfusion. We don't necessarily always use excess fluids because excess fluids can cause fluid shifting and further cord swelling. They may use vasopressors to keep that blood pressure up if we need to. Maintain the heart rate greater than 60. If your heart rate is dropping or your blood pressure is dropping from neurogenic shock, then the treatments are going to be atropine or external pacing for a decreased heart rate. So that's whether it is because of neurogenic shock or just in general. If you have a decreased heart rate from neurogenic shock, why would you not give epi? Any thoughts? Why wouldn't you just give epi or dopamine to up your heart rate? Because those things will give sympathetic response. But our sympathetic stimulation is not working. So the only thing that we can do, this will block that overactive parasympathetic. Sympathetic. Okay, I can't draw. You know what I'm trying to say. This will block your parasympathetic stimulation. So basically that is a parasympathetic blocker, and it will tell the heart to stop listening to that parasympathetic system, and then the heart rate will come up on its own. If it does not come up on its own after atropine, then they will pace the heart until that neurogenic shock resolves. There's nothing really we can do to boost that heart rate. Epi doesn't work, norepinephrine doesn't work. All the things that we usually do to stimulate a heart rate are not really going to work. So we're going to try atropine external pacing. To keep the blood pressure up, again, sympathetic is not going to work. So epi, norepinephrine, those two are out. They will probably use just potent vasoconstrictors. And does anybody know, going back to way back to your hemodynamics lecture, which vasoconstrictors are pure vasoconstrictors? The vasoconstrictor that they'll try to use and has the best would be neosynephrine. Or it's known as Neo for short. That is probably our most potent vasoconstrictor. They may try epinephrine or Levophed, but again, your sympathetic stimulation that those drugs do is not functioning properly. So they will try to do vasoconstrictors to bring that mean arterial pressure up. But in spinal shock, if we can usually get the heart rate, not spinal shock, in neurogenic shock, if we can get the heart rate up, then we can usually get the blood pressure back up. So what we're going to be doing is watching the heart rate, blood pressure, and respiratory rate. If the respiratory rate starts to drop, then we can, there's intubation, there's bag valve, there's support if you start dropping your respiratory rate. We will give atropine and pace the heart rate, and they will give vasopressors to keep the blood pressure up. So neurogenic shock, again, it is sympathetic stimulation. So giving atropine, which blocks parasympathetic stimulation, should help your heart rate, blood pressure, and respiratory rate. So number one for neurogenic shock, and I'm just going to put that there. We're just going to write that there. Atropine is your number one for neurogenic shock. And that is because it's going to block the super uninhibited parasympathetic stimulation that is going on. And once we block the parasympathetic system from telling everything to slow down, then everything should speed back up again. So atropine is really the only drug in our arsenal. We can try the vasoconstrictors, but again, neosynephrine and epinephrine and norepinephrine and dopamine and dobutamine, they all work mostly on the sympathetic system. And if the sympathetic system has been knocked out, then they're not going to work all that well. I think neosynephrine is the only one that really works decently well in spinal cases. So anyway, high-dose steroids, those are up in debate right now. There used to be every spinal cord injury would get high-dose steroids, but then they found out that the high blood sugar that the high-dose steroids caused were causing more damage to spinal healing than it was worth. So you may see high-dose steroids still available, but I know when people have swelling, they think steroids, but unfortunately the doses high enough to decrease spinal swelling do cause increased glucose levels, which then impairs healing. So kind of a give and take sort of thing there. But anyway, the number one treatment for neurogenic shock is atropine, but we do want to maintain oxygenation, even if it involves ventilation. We will go all the way up to ventilation. They need to maintain oxygenation to the spine and maintain perfusion to the spine. So stabilize, oxygenate, perfuse, and manage neurogenic bladder and bowel. Again, the patient is at risk for pyelonephritis and hydronephrosis and renal damage if you have urinary retention over distension of the bladder. Bowels may be over-innervated with the parasympathetic system, so that's not usually a problem, but if you have a neurogenic bowel that is not being innervated enough, there could be issues with needing to be NPO if you have an ileus, NG tube, NPO if there's an ileus. But again, most of the time, spinal patients need a lot of nutrition. They need a lot of hydration, not overhydrated, adequate hydration. We want high protein, high calorie diet, and if your patient is not up to eating, they may do supplemental feeding, and that might be through an NG, a feeding tube. Really, paralytic ileus is rare. But if decreased sensation is happening, then it is a possibility. So we would want to keep an eye on things, but the bowels are usually innervated by the parasympathetic system, which is working just fine. So keep an eye on the bowel sounds. Keep an eye on whether they've had a bowel movement or not. What may be disturbed is the innervation to the rectum that will say they need to have a bowel movement and they end up getting constipated. So they may need to be put on a bedpan at certain times of the day. It depends on what phase of the acute phase they're in and how easy it is to move them, but it's very easy for patients to become constipated with abdominal distension. So definitely a bowel program to prevent constipation. Keep an eye on the bowels. Keep an eye, just because they're hypoactive bowel sounds doesn't mean we don't feed them. We still want supplemental feeding for energy and tissue repair. We're just going to make sure that things are moving through the gut appropriately. They may need enemas. They may need rectal stimulation. There may be other ways to get a bowel movement going. We don't keep them NPO unless they have an ileus. Indwelling urinary catheter is usually for the first few days, but after 3 to 4 days, it should be considered that to go to an intermittent catheterization schedule. But because they're very prone to UTIs with the bladder retention, so they will probably be indwelling urinary catheter right after a spinal injury. But after, up to a week in the hospital, after that, we need to start thinking about long-term bladder management. So we'll be looking at that. Maintain normothermia. Again, if you're going through spinal shock, they may have an inability to regulate their temperature, so monitor the room closely, maintain appropriate body temperature. Stress ulcer prophylaxis is a big injury, definite risk of stress ulcers, and skin care. Just because your patient has a spinal injury does not mean we don't turn them. They will be log rolled by you and 2 of your best friends every 2 to 3 hours. Keep them on their side. They just have to be moved as one unit, but they can be moved. If it's too dangerous to move them, they're too worried about spinal swelling, then they do have rotating beds that are designed for patients with spinal cord injuries to reduce pressure sores. But a pressure sore could be a death sentence for a spinal cord patient that can't feel it and has delayed innervation and healing. So take care of your spinal cord patients. Make sure that the braces, collars are removed for hygiene purposes, that they are log rolled. Just do it safely, maintaining spinal immobilization as you do it. Then we're just going to go to the rehab phase real quick. So basically, immobilization and maintaining perfusion and watching for bowel problems is the highlight of care, and the main points of care for spinal cord patients. After the first 12 weeks of spinal cord injury, now you're starting to see your spine is stabilized, the bone healing is stabilized, a more accurate prognosis of your long-term injury. Spinal shock should be worn away. What you are left with is probably what you're going to be living with. There can be some healing of nerves, but not many. They're doing a lot of new invasive treatments for stimulating nerve function and spinal cord injury repair. Again, I'm not going into everything. I just want to point out the highlights in the rehabilitation phase, which is basically our one disorder of the rehabilitation phase is autonomic dysreflexia. And then the most common complications are pneumonia, bowel bladder dysfunction, and skin breakdown. So autonomic dysreflexia is our one disorder of spinal cord injury that kind of stays with you if you are an injury T6 and above. Again, this is resulting of improper sympathetic stimulation due to a long-term injury, T6 or higher. These patients have an inappropriate cardiovascular reaction to an irritating stimulus below the level of injury. So if you are injured at T1, anything that happens below T1, anything that you would have normal function for, any irritating stimulus is going to cause this feedback cycle, which is involved in the sympathetic and parasympathetic system. But usually the most common causes are distended bladder, constipation. Those are the most common irritating stimulus below. The patient can't feel it, but it's still trying to send messages up to the brain. It's just that the highway's broken there. We're trying to send out emergency signals. The bladder is like, I need to go. The rectum's like, I got something in me. But the signals are not reaching the brain appropriately. Tight closed socks, elastics, pressure ulcers, anything that's a constant sensory irritant below the level of injury can cause autonomic dysreflexia. The cues for it are a severe headache, a pounding, throbbing headache, severe and rapid hypertension, and combined with bradycardia. It's basically inappropriate signaling, and those are the three major cues. Your patient will have a blood pressure, it could be 200 over 100 with a heart rate of 58. Don't try to make sense of it. It is autonomic dysreflexia. Sit them upright. That's the main thing you're going to do. They are sweating and flushed above the level of injury and cold, pale, and dry below the level of injury. I found all these videos are from the Christopher Reeve Foundation. If you click on them, they are short videos that walk you through it better than I can. What autonomic dysreflexia is and why it happens. So definitely grab these quick little links and watch those along with this PowerPoint. So pounding headache, severe hypertension, bradycardia, recognize it as autonomic dysreflexia and treat it. Here's another picture of autonomic dysreflexia. And patients should know that they are prone anything above T6. If they've had that injury, they'll know that in the rehab phase they are prone to autonomic dysreflexia, and to recognize those symptoms. When they have these symptoms, they need to go sit themselves upright if they aren't already. If you're taking care of the patient, sit them upright. That is to reduce they have severe hypertension. We don't want that affecting cerebral vessels and blowing anything. So sitting them upright will decrease the pressure to the head. So kind of like when you don't have a blood pressure, you Trendelenburg the patient. So when you, if you have a decreased blood pressure, you put the patient on their head, right? If they're fainting or whatever, you put their legs up and their head down. If you have an increased blood pressure, we're going to do the opposite, okay? Head up. This is just a quick thing that we're going to do to help drain blood from the brain. So just like if you have a decreased blood pressure, you drop their head. If you have an increased blood pressure, you increase the head. Okay. You just love my drawings, don't you? You're going to miss these guys. Sit the patient upright. Get them elevated. Then you're going to perform an assessment from the feet up and start looking for causes. Have they been catheterized in the near recent, maybe bladder scan them, see if it's time for catheterization. Have they not had a bowel movement in a while? Maybe there's something crowning down there you got to take a look at. Are there some clothes that are on? I mean, undress them from the bottom down. Get any irritating stimulus out of the way. And if you've completely undressed them and looked for bowel bladder issues and cannot find the cause, then you need to call the provider and find out what other things you can do. But since pressure sores, constipation, bladder distension are our common cause, making sure that we're not developing a pressure sore, avoiding constipation, avoiding bladder distension, and we have how to do that in the next few slides. But we're trying to, if it's just a belt or maybe a sock that's turned over the wrong way and digging into the skin, sometimes removing clothing will remove the autonomic dysreflexia. And once the irritating stimulus is removed, then the symptoms will go away. So you hit the jackpot when you rip off a sock and then all of a sudden the blood pressure comes down and the heart rate comes up. Well, that was it. So it could be anything, but sit the patient upright first and then try to figure out the cause after they're sitting upright. A big complication in spinal cord injuries, especially in the thoracic or cervical, is decreased respiratory movement. If you are cervical and mechanically ventilated, you're constantly at risk for pneumonia or respiratory infection. Maintaining suctioning, atelectasis, doing coughing, deep breathing with the patient, chest percussion, vibration, postural drainage, all those things with mechanically ventilated patients. They're constantly at risk for respiratory infection because they have an airway that is introducing things directly into the lungs. If they just have weak thoracic, maybe they have a thoracic injury, and they just have weak chest muscle movements, there is assisted coughing and breath stacking. Breath stacking can also help a mechanically ventilated patient to cough. I will let you watch those videos, but assisted coughing is where you actually physically kind of Heimlich the patient to get them to cough. You're physically forcing air up the diaphragm so that they can expel some air. It's almost really very similar to the Heimlich maneuver, assisted coughing. Breath stacking is where you take an ambu bag or a bag valve mask and you actively, physically, and a patient can do it themselves. If they could take multiple small breaths and hold them in between, you actually end up filling up the lungs, and then you can exhale that all as a cough. So I have those videos there queued up for you to watch on assisted coughing or breath stacking, which are ways we have to keep secretions out of the lungs. They do need to cough. They just probably don't have the respiratory strength to cough. If you have a thoracic injury or a cervical injury, those respiratory thoracic chest muscles are just weak. Very hard to pull effective in center spirometry if your chest muscles are not innervated well. So there are phrenic nerve stimulators, diaphragmatic pacemakers, which will get you breathing appropriately, or at least stimulate the diaphragm. That's if you have C4 or higher and your diaphragm is damaged. They might be able to do diaphragmatic pacemakers, which is basically setting a respiratory rate, stimulating your diaphragm. Your diaphragm is not broken, it's just not innervated anymore. And so diaphragmatic pacemakers will provide a stimulus to the diaphragm, 12 breaths per minute, and will stimulate that diaphragm to contract and pull in air. But again, if you have weak chest muscles, you may not, even with a diaphragmatic pacemaker, be able to pull very effective, good deep breaths, which is where the breath stacking and assisted coughing come in. So those are things that are in the rehab phase that are very important to avoid pneumonia or respiratory infection. If your patient has cervical or thoracic injuries, you can't very well tell them, take a deep breath. The nerves and the muscles just are not there to do so. So we'll have to help them do that. Neurogenic bladder, urinary retention. Again, there is a quick bladder management video to watch. We don't want patients with neurogenic bladders to avoid drinking. They still need adequate fluid intake, but you could put them on a voiding schedule if they have it. So neurogenic bladders could be spastic or flaccid or a period of both. For spastic bladders, we would decrease the bladder spasms with anticholinergics, antispasmodics. With a flaccid bladder, the patient may be on an intermittent catheterization schedule. They could have external catheters. They have the PureWick for women. They have condom catheters for men. Because as the bladder distends, it might have overflow incontinence, so they may be more comfortable with an external catheter or pad or something. They do have electrical stimulation that will cause the bladder to retract at certain periods, kind of like a bladder pacemaker. And then if there are frequent UTIs and the patient can't manage the intermittent catheterization schedule, they can do urinary diversion to just allow that to be taken out of their hands. So there are a couple of things for bladder management afterwards. Bowel management, avoiding constipation, high fiber diet, adequate fluid intake. Remember, keep things moving, and then they should have a bowel evacuation schedule. There is a gastrocolic reflex induced by eating. I don't know if anybody's had their morning coffee and needed to go to the bathroom. That is your gastrocolic reflex. It is stimulated by eating, and you can position the patient for a bowel movement 30 minutes after the first meal of the day and hope that the reflex provides a bowel movement. There's other ways to stimulate bowel movements as well. Warm beverages, regular exercise, suppositories with digital stimulation, stool softeners, keep the bowel moving and excreting. And pressure ulcers, the big key takeaway for pressure ulcers is that the patient needs to reposition themselves if they are up out of bed or get assistance with repositioning. Reposition every 2 hours while in bed. You have a larger part of the body distributed over the bed weight. So you can turn every 2 hours while in bed. But if you are sitting upright in a wheelchair, all of your body weight is being put on a couple of bony prominences, and so that needs to be something that the patient can have a timer. If they have upper arm movement, they may have to physically have a timer on where they have to physically shift. They're not going to feel that they're getting a pressure sore on those sitting bones, on the back of the knees, on the tailbone. That is your whole full body weight basically resting on a couple of bones, whereas when you're laying out in bed, you have your whole body weight distributed over a larger so you can go every 2 hours while in bed. But if you're sitting up in a wheelchair, they should be shifting themselves every 15 to 30 minutes. They should also be taught to do a full assessment of skin and bony prominences, either by themselves with a long-handled mirror to look at areas that they can't see on their own, or have somebody do the skin inspection for them. To look for reddened areas, any cuts, bruises, scrapes, looking for infections, reddened pressure sores, because the major causes of death of patients after spinal cord injury are septic pressure ulcers and pneumonias. And those are the major causes of death. So you survive your spinal cord injury just to be taken out by a secondary infection. So preventing those secondary infections with good stacking, coughing, deep breathing, and a skin assessment, and repositioning frequently. And that is all I have for you on spinal cord injuries. Please let me know if you have any questions or concerns, and have a great day.